study was enhanced by my colleague Dr. Samhita Panda to know in healthy population how common is the sleep disorder. In Western world, the literature says about a third of population have it. We did about this questionnaire administration in about 1,000 odd healthy population. And you can see that the range varied from 20 to 34% depending on which instrument we used it. The insomnia was about in 18%, so was the snoring. Sleep apnea was in about close to 8%, RLS about 3%, nightmare in 1.5%, and sleep talking in 2 points. Among the sleep insomnia, difficulty in initiating sleep was almost 18%, so was maintaining sleep, and early morning was also reported in close to 8%. And when we try to see the relation of any other comorbid illness responsible for the insomnia, it was depression and anxiety. Now, this was the kind of age distribution of the sleep disorders, and this was the overall 1,000 individual, about 700 odd sleeping for the required more than 7 hours and 250 odd sleeping from 6 to 7 hours. Rest were in the lesser category. Now, several catastrophes in our history are thought to be related with sleepiness and fatigue. Some of them are Chernobyl nuclear disaster, which happened because of, people say, early morning, when the early warning signs were not picked up, the persons on duty were sleeping. So did the Bhopal gas disaster in 1984, and even the Challenger space shuttle disaster, there were errors because of the sleepiness. It affects the mood, behavior, our work, quality of life, and contributes to morbidity and mortality. And many of the primary or secondary disorders can affect sleep. Among them are neurological illness. Then we all know about psychiatric illness, which can also affect sleep. There are some systemic illness like liver dysfunction can directly affect the sleep. If you have lots of pains and all, you cannot sleep, so musculoskeletal. So among the neurological disorders, epilepsy, movement disorders, dementia are there. And we know that epilepsy is a common disorder, but how common is sleep problem? A rough guess is about 50% of the patients with epilepsy will have some form of sleep problem. So people living with epilepsy, sleep disorders are frequently overlooked, and its diagnosis and treatment obviously can improve the quality of life and some cases seizure control. A complex and reciprocal relationships exist between sleep and epilepsy. We'll see how in coming slides I will try to bring out that complex relationship. There is also some relation between epilepsy and circadian rhythm. Now let us see some examples. A 21-year-old man on 180 milligram of phenobarbital or Gardinal comes with excessive daytime somnolence. It's obviously because of the drug phenobarbital. A 16-year-old girl of juvenile myoclonic epilepsy on valproate 400 milligram per day comes with history of having myoclonic jerks early morning on sleep deprivation. Now this is related with epilepsy and circadian rhythm, like JME patients early morning, and they may have these jerks. A 4-year-old girl on multiple seizure types on polytherapy following start of lamotrigine, mother complaints of decreased sleep. Now lamotrigine is known to cause insomnia in certain proportion of children. A 35-year-old man with daily nocturnal stereotype event since age 10 with vocalization along with posturing of one limb, one occasional incontinence, no daytime evening, but often somnolent, drug resistant. General practitioners thought it could be non-epileptic events. We all know this is nocturnal frontal lobe epilepsy. A parent of a 6-year-old girl with history of one episode of brief generalized seizures 1 year ago, and there has been a recent drop in language milestones with EEG recorded during sleep, shows continuous spike wave discharges. Now, this is an interesting phenomenon known as Landau-Kleffner syndrome or acquired aphasia, epileptic aphasia, and a whole lot of gamut of epilepsies come. And seizures and continuous EEG discharges in sleep, especially slow wave, can affect the language and cognition of the child. So these are some of the examples I wanted to share, so that how patients with epilepsy, they come to clinic with these problems. Now, epilepsy during sleep can be benign childhood epilepsy with centrotemporal spikes, early onset benign childhood occipital epilepsy, frontal lobe epilepsy, example which we saw, another familial frontal lobe epilepsy. Then the last example was for these two, electrical status epilepticus during slow wave sleep and Landau-Kleffner's syndrome. While awakening, one patient example was JME. There could be others like absence epilepsy or grand mal seizures on awakening. Now, in the history also, several key persons have tried to highlight, like Aristotle and Hippocrates called it sacred disease, and they told it may be promoted by sleep. In 1885, Gower, who was the father of epilepsy, reiterated the relationship between of seizures to sleep-wake cycle. Gibbs, who worked on the EEG and a lot of EEG and epilepsy in the 1940s and 50s, found IED's activation during sleep. 1962, Jans, who described the JME or juvenile myoclonic epilepsy, differentiated awakening, nocturnal, and diurnal nocturnal epilepsies. Now, we all know this is a polysomnogram, and it's a typical graph. And you can see the first four are the EEG waves. So in the polysomnogram, one of the major component is the recording of the EEG. So the C3 channel is connected to A2, C4 is connected to A1, and O1 is connected to A2, and O2 to A. So 4 channels are minimum required. That is a requirement. You can enhance to 8 channels or 16 channels if your system allows that. More the merrier, but obviously it becomes more tedious, but minimum 4 are required. So this is how it is placed. Now let us see some nocturnal events. One lady, she gets up from the sleep, has confused state, she is restless, there is a pelvic thrusting, then there is a twisting movement of the lower limb. She tries to have automatisms. So this is a typical frontal lobe epilepsy. I will show you another frontal lobe epilepsy. He also gets up from sleep. Again, you can see that he is very hypermotor. He has bicycling movement of both the lower limb. This is a classical frontal lobe epilepsy. So both are known to happen during sleep. Now, these are two movements which can normally be there. The first one is a PLM, or the periodic limb movement. You can see the left toe going up, and in the EEG below in the polysomnogram, you can see. So you require 5 in a given epoch to call it PLM. So this is a classical PLM movement or periodic limb movement. This is just an isolated movement. So this is an isolated movement with possibly one nocturnal myoclonus, or what we call the sleep. So this is a true myoclonic jerk in a patient with juvenile myoclonic epilepsy during sleep. And this is a patient with dementia having REM behavior disorder. So initially he started talking irrelevantly. Then there is a dream enactment behavior, bizarre. So these are the various problems which one can face during the night. So to see the sleep events, what are the differential diagnoses? So you can see the non-REM parasomnias, REM behavior disorder, nocturnal seizures, or even psychogenic events. Now, when we see the non-REM parasomnia, it is in the first third. The REM behavior will be the later 1/3 or midnight onwards. And then nocturnal seizures can happen anytime, mostly during the first 2 hours or last 2 hours. Now, seizures, obviously, they cannot recall. REM behavior, rarely they may have dream recall, non-REM also cannot recall. This stereotypal movement is only in nocturnal, like one seizure will be like the previous one or the next one, that is the stereotyping. In the polysomnogram, this is arousal from the delta sleep, that is non-REM. This is like a REM behavior disorder. You have a flat EMG tone and suddenly patient has that kind of behavior. In here, you can see EEG potentially epileptiform activity. Psychogenic seizures, even most of the time, even if the person was sleeping, gets up just before the event. Now, there are at times students or residents may have difficulty in differentiating between frontal lobe seizures and non-REM parasomnias. So we use what is known as FLEP scale, and when the onset is less than 55 years, duration of event is less than 2, timing within half an hour of sleep onset, prominent dystonic, stereotype, lucid call, this may favor frontal lobe. Overall, there could be this kind of abnormality may happen in about 50% in a day lab, but when you do 24-hour, you can have high degree of abnormality and can sort out the differentiation. Now we'll go to the topic per se with this background. Now, how does the epilepsy or the anti-seizure medication affect the sleep? Now, the commonest one is like the excessive daytime somnolence in persons with epilepsy. Nearly a third of people living with epilepsy have elevated score on ESS. The cause could be many. One, obviously, the anti-seizure medication. Nocturnal interictal discharges and seizures will cause break or in the sleep. Person is not able to sleep properly. So next time, person will have increased sleepiness during the daytime. There could be associated primary sleep disorder in persons with epilepsy, like sleep disorders, breathing, or RLS, which can result into increased daytime sleepiness. Now, correction of these sleep disorders can improve seizure control. Now, this was one study which we did about 10 years ago, in which the patients with juvenile myoclonic epilepsy and controls we took, and this was the kind of the first study in JME where we found significant sleep disturbances, and there was excessive daytime somnolence, disturbed night sleep despite adequate medication and good seizure control. So we also did polysomnogram in those patients, and polysomnogram studies revealed that there was a significant alteration in sleep architecture in JME despite good seizure control, and there was variable degree of polysomnographic abnormalities and phenotypic correlation. This is in a stage 2 or N2, you can see discharges. This is in a REM, you can see polyspikes coming. We were using 8-channel EEG. Now, further, Bazil, who has been one of the authority in sleep and epilepsy, he also found that there was increase in sleep latency and increase in number and duration of awakening. At the same time, there was decrease in sleep efficiency and reduction in or fragmentation of REM. So these findings were more common in generalized than in partial in their studies, and severe in symptomatic epilepsies which were associated with neurological disorders. Now, similarly in their study, they compared the seizure-free nights and compared with the seizure-free nights, patients with seizures during overnight PSG had significant decrease in REM and increase in stage 1 sleep. And if a seizure occurred before the first REM period, the effects were more pronounced. Thereby, that the good control of seizures has a good effect on the sleep architecture. And if there are seizures on the night, the architecture, including the REM, gets altered. So this table, actually, there are several studies which I have put it. So there are authors have found either REM was decreased or sleep efficiency of patients with interictal activity was lower, or again, another author found sleep efficiency was lower with percentage of REM being increased and REM being decreased. even children with poor seizure control demonstrated lower sleep efficiency. So overall, it means that yes, sleep efficiency gets decreased. That is one. Some authors have found daytime sleepiness being more. Some authors have found more arousal or decreased REM. So these are the other polysomnographic findings. Now, there are rare studies in which there were no difference between this patient was like a control along with non-epileptic seizures. Then authors have also found increased non-REM stage 1, decreased REM, that is replicating the previous page table. And now there was an interesting study which one of my PhD students did about 5-7 years before, and we took about 160 odd subjects. There were 120 patients and 40 controls, and 120 patients were again 3 groups: 40 juvenile myoclonic, 40 temporal lobe, and 40 extratemporal, of which 20 each group was drug naive. And to have a like a less variable multivariable effect, we try to keep on single drug. So the JME patient drug of choice is valproate, and in the partial seizures group, that is temporal or the extratemporal epilepsy, we try to keep on carbamazepine. So in this, one of the finding was like the sleep questionnaire, persons with epilepsy had higher PSQI but comparable ESS, and patients with juvenile myoclonic epilepsy, there was higher initiation and maintenance insomnia and nocturnal myoclonus. Similarly, in the polysomnographic observation in JME and TLE, it was compared with the healthy controls, while in the extratemporal loop group, there was a high wake percentage and REM arousal indexes. So for overall, people with epilepsy in our cohort had better sleep quality, because possibly that our evaluation at the early stage of the disease and removal of the confounding factor of ASM. In the previous, most of the studies, the confounding factor of multiple anti-seizure medication was not taken into consideration. And so this also led to several publications. One is comparing the sleep profile between the patients with JME and partial epilepsy. And this study, we found that patients with epilepsy have higher prevalence of poor sleep quality compared to controls. Moreover, a significant higher percentage with partial epilepsy had higher ESS score compared to the healthy controls. Now, Dr. Chetan's study also, based on the sleep questionnaire, found that valproate beneficially modulates the arousal instability in patients with JME, hence promotes sleep quality and continuity. They were telling valproate is one drug, probably it has got least effect on worsening the sleep. Now, there was this previous observation was based on this study, that there was patients who were on valproate, there was a significant improvement in nighttime sleep quality and with valproate treatment. And however, valproate did not alter the ESS. Now, what carbamazepine does on sleep profile on patients with temporal lobe epilepsy or extratemporal lobe epilepsy. So Dr. Nayak's study found that the ESS, PSQI, and the NIMHANS score, as well as the sleep microarchitectural parameters, were comparable between drug naive and carbamazepine. So probably carbamazepine augments sleep instability in patients with TLE and extra TLE without affecting the sleep architecture. Now, there have been other studies which have found that there are complex relationship, like sedating effect of most of the older anti-seizure medication, insomnia associated with ACTH, felbamate or lamotrigine, insomnia associated with withdrawal like phenobarbital and benzodiazepine, sleep disorders breathing sometimes because valproate causes obesity, and VNS also can sometimes be related, cause SDB or sleep disorders breathing. RLS can worsen with DPH jonisomide, however, can benefit with valproate, gabapentin, carbamazepine or lamotrigine. So we'll see one important aspect, that is the relation with arousals in sleep and what happens there. So arousals are transient, do not result in behavioral awakening, and it could have a de novo or idiopathic, or sometimes the stimulus could be apnea, pain, or PLM. EEG arousal is abrupt shift of EEG frequencies during, including alpha, theta, and or frequencies greater than 16 hertz that lasts very short, that is about 3 seconds or so. Now, there's at least 10 seconds we should have sleep preceding or between the arousals. This is an arousal in REM sleep. So how we measure the arousal indices? An arousal index is defined as number of arousal per hour of sleep. Normally it could be up to 10. And the arousal analysis, we need to see spontaneous arousals, desaturation, leg movement, snoring, and apnea. So what is not an arousal? So when there are artifacts, K complexes, delta waves without EEG frequencies, it's transition from one stage to another, pen blocking artifacts, continuous EEG and EMG changes which are individually less than 3 seconds, and alpha intrusions in non-REM lasting for less than. So this we don't call it an arousal. Now, epochs with low amplitude missed frequency EEG, but when there is no K or spindle, preceded by epoch with K complex without arousal or previous epoch with spindle, we continue as N2. Now, there is something known as this sleep arousal transition is very unstable period. Why it is important to know this unstable or the instability? Because in this period, the discharges are noted, and during this period, the seizures can happen. So one of this transition period is known as cyclic alternating period pattern, or CAP. The repetitive stereotyped EEG pattern is about a minute, separated by time equivalent intervals of background activity. Now, if anybody is interested, we can discuss about it in a bigger way. But CAP is an important observation which we see in non-REM sleep. We can have phase A, that is, you can see high amplitude activity. Phase B is little quiet. Again, phase B, A, and phase B. So one phase A to completion of phase B is a CAP cycle. The complete occurrence of phase A, phase B, phase A and B is a CAP sequence. Overall, it lasts for about 60 seconds. Now, obviously it occurs in non-REM, and this A is further divided into A2, A3. And what happens, there is a synchronization of the EEG during this activity. And because of that synchronization, one is prone for the seizures or the interictal discharges. So in Chetan's thesis, what we found that there was a higher CAP rate and lower CAP duration in patients with JME and TLE. Similarly, in extra TLE, there was higher CAP rates on cycling. So what does it mean? It means that this microarchitecture analysis is more affecting and identifying subtle alteration in sleep quality that is often missed in our staging only looking. Now, his study looked into again how CAP and the drugs were related. So he found that the valproate beneficially modulates arousal instability in patients with JME, hence promotes sleep quality, and this was based on that publication. Similarly, carbamazepine also augments sleep instability in patients with TLE and extratemporally without affecting the sleep architecture. Now, poor seizure control leads to poor sleep, and which leads to poor seizure control. This cycle goes on and on. So nocturnal seizures can fragment sleep. This can be generalized, but this can be generalized seizures, but we often see in partial seizures, which can wake the people when we monitor them. Now, this sleep architecture is a complex cartoon showing how this can affect the relationship between the CAP and the interictal discharges. So you have increased CAP, impaired CAP B, these are interrelated, and ultimately this affects there is because of this synchronicity, we get interictal discharges. So once you get interictal discharges, it can cause recurrent interictal discharges during this, like conventionally known arousal indices are gay complex convertive sharp waves, and which causes seizures. Now, do some seizures generalize more often during sleep? So you can see this is gray is asleep and awake is the blue marker. So more often in occipital lobe epilepsies or even temporal lobe epilepsies, this was noted. We also found in one of my study when long back when I was in the UK, that secondary generalization occurred more often in sleep than in awakening, and perhaps due to facilitated spread of seizures during sleep. Now, all this time we were talking about well-controlled epilepsies, newly diagnosed, single drug. Now, one of our student, Dr. Sai Deepak, he worked on patients with refractory temporal lobe epilepsy due to hippocampal sclerosis and studied their sleep profile. And he found that patients' mean ESQI compared to the control is definitely, you can see it's more. And many of the polysomnogram parameters were also altered compared with the controls. So this, we also did the study. These patients with temporal lobe epilepsy with HS undergoes surgery. So after surgery, seizures get controlled. So what happened to these sleep parameters? So when we started looking into these sleep parameters pre-op and post-op, there was not much of change. So we are a little surprised why this happened. Probably our follow-up was very less. It's about 5 months when we did this pre and post-op. And another problem is that we don't change the medication. Like the improvement probably will be seen after we take out the medication. And the medications are generally taken out only after a year or two. So probably long-term follow-up may give a different kind of picture compared to first 3 or 6 month evaluation. Now we'll flip the coin as to how does sleep affect the epilepsy. Now, presence of sleep and awakening, we have seen that in particular type occurs during sleep and awakening. Seizure, sleep induction and deprivation can activate epileptiform activity. Temporal patterns of sleep occurrence during sleep. Non-REM sleep activates and the REM sleep inhibits epileptiform activity. Similarly, periodic arousal instability and cortical synchrony promote epilepsy during non-REM. So seizures tend to occur during specific stages of sleep, which are very complex and dynamic phenomena involving multiple neural networks. And experimental models have demonstrated the modulating effect of non-REM and REM sleep on epileptic foci. Now, there one element in a common community, there is a medical term known as obstructive sleep apnea. So it's much more than snoring. The apnea happens during the sleep, and which can affect many, like hypertension worsens. It's an independent risk factor for coronary heart disease. It's an independent risk factor for stroke. So similarly, it is believed that seizures worsen because of when there is associated OSA. And if the persons are treated for OSA, there is a good amount of seizure frequency decrease, or even some of them are lucky to be seizure free. So several authors have looked into, and they have found that if we treat OSA, there is a definite decrease in seizures. Now, in primary or idiopathic generalized epilepsy, an activation of interictal discharge is observed during somnolence after awakening, but during non-REM sleep, especially during light sleep. However, ictal activity occurs in transition periods during sleep-wake cycle, especially after awakening or in daily phases of somnolence. However, in partial seizures, frontal lobe most likely during sleep, temporal lobe seizures during intermediate sleep states like N2 or the stage 2 sleep promotes secondary generalization of temporal and occipitotemporal, not frontal. So these findings suggest that there is a hypersynchrony of sleep, facilitates both initiation and propagation of partial seizures that affects the sleep depend in the part of the location of the epileptic foci. So IED gets activated in both focal and generalized in about 30%. Epilepsy syndromes associated with marked activation are the Rolandic epilepsy, or that is benign epilepsy with centrotemporal spikes, Landau-Kleffner syndrome, epilepsy with continuous slow wave sleep. In temporal lobe epilepsies also, IED occurs maximum in non-REM, and sometimes it is seen in bilateral. So these are two studies which we did, one study which we did, and it kind of agreed with the previous study that periodic instability, activation of AEDs, which may cause poorly controlled epilepsy, that is nocturnal AEDs, which cause sleep fragmentation. Sleep fragmentation indirectly will cause periodic. So it becomes a vicious cycle. Now, we also tried to analyze in Dr. Chetan's thesis, came back now again. So we analyzed the spike rate. So we found that the spike rate was, you can see that it was significantly more during the REM phase in JME patients compared to the others. And now, there was again, along with the spike rate, and so when the spike rate was more, there was a decrease in sleep efficiency. When the spike rate was more, the cap cycle indices was more. So authors have also looked into how this EEG or spike wave, when it is there, it affects the learning and the quality of life. That means when the sleep spike wave is more seen during the EEG in non-REM sleep, it affects the learning, it affects the quality of life. So coming back to this, non-REM is a facilitator of sleep, REM is prevent seizures. So this balance between the non-REM and REM is very important, and it gets altered in sleep. So moment there is more of synchronization, it facilitates epilepsy or seizures or interictal discharges in non-REM, while it is reverse in REM. So this is just that table telling the same thing which I was just now telling. The last part of the discussion is, so what have this, we all know that during seizures or interictal there is a increased synchronization. So what happens during this sleep? So in Dr. Chetan's last objective was to see whether what happens in sleep during these discharges, whether there is a what happens to the cortical synchrony. So he found there is a heightened background synchrony in patients with epilepsy compared in the sleep compared in the awake stage. So there was in the delta and in other frequency band as well. So cortical degree of it was significantly modulating by various stage of vigilance in health and control, and patients with epilepsy had a significant higher background cortical synchrony compared with the healthy adults. So it means that yes, we found some basis or it was a good observation that in non-REM we found the rates were more, seizures were more. So one of the physiological reasons could be that yes, there is a heightened cortical synchrony which is there in these patients. Now, we all know that there is one entity known as SUDEP, that is sudden death in epilepsy. And there are various reasons. Nobody exactly knows why SUDEP happens. So one could be autonomic instability, then sudden apnea or pulmonary edema or those kind of choking. So various reasons are put forward. So what we did, we studied the heart rate variability during the apnea, which normally happens in patients and in the controls, and we selected those apnea period, and looked for the heart rate variability. So there should be heart rate variability, right? So we did not find the heart rate variability in JME patients and in temporal lobe epilepsy. Now, whether this is a small marker which we can say that it can be a biomarker for SUDEP was just one hypothesis which we shared in these two publications. Now, there is one more thing known as circadian rhythm and epilepsy. Now, this knowledge is from day to day, we know that yes, JME patients have in the early morning frontal lobe epilepsy patients or Rolandic epilepsy patients or Landau-Kleffner more have in the night time. Now, some of our epilepsy patients in the West are undergoing responsive nerve stimulation, RNS placement. These are neurostimulator which is placed within the brain. And this data is continuously being collected in for individual patients. So now people have found out that this data initially came for weeks, then months, years. Now it's almost for 5 to 10 years data has come. So from circadian rhythm to ultradian rhythm has come, and there is a lot of, like, some patients will be okay for a few months. Next few months he may not be okay. So this kind of behavior is being studied, and why this happens is not very clear. So these are some of the like you can see from October 05 to June 20, so 2 years period, what happens, and there are peaks in which the seizures happen. There are other periods when there is nothing happens. The exact reason, we are trying to understand a new phenomena, but we are not fully clear as to why it happens. Now, I'll probably try to summarize now that yes, epilepsy and the effect of anti-seizure medication causes sleep quality by frequent ictal and interictal discharges in sleep, which causes recurrent sleep arousal instability, sleep fragmentation, altered sleep-wake cycle, disrupt sleep architecture, and sleep fragmentation. This causes decreased sleep efficiency, increased sleep latency and REM latency, increased number of arousals and awakenings. To summarize, sleep themselves can disrupt, seizures themselves can disrupt sleep even when they occur during wakefulness, but the exact mechanism is not known. Sleep stages represent forms of varied neuronal synchronization that influence epileptic activity. The occurrence of seizures has a pervasive effect on sleep architecture, particularly during the post-ictal period in generalized seizures. Factors such as type of epileptic syndrome, seizure type, degree of previously associated neurological involvement, use of anti-seizure medication may be associated to alteration in quality of sleep and architectural problems. So probably students, we now know that there is a reciprocal relation between epilepsy and sleep, and it's very complex. And I think a lot more studies are required as to why it really happens. Some of the things are in the hypothesis stage. Some of the things have a better understanding over a period of time. More importantly, like good seizure control improves sleep and vice versa. That is one thing. I must thank Dr. Chetan especially, who most of his these studies were based on his study. Thank you once again. Any questions? I am ready.
Yeah. Thank you, Dr. Sinha, for that very educative talk. We can look into the chat box for the questions. What is it? Question may be coming. All compliments for you.
What might be the role of sleep deprivation in epilepsy? Yes, it's an important question. And when any patient comes to clinic, we definitely say that be on sleep. You're deprived of sleep. Actually, any epilepsies can provoke, but it's most true for patients with juvenile myoclonic epilepsy. Like even if the person's sleep is well controlled, and for suppose there was a marriage at home, or the person is traveling and the person is sleep deprived, studied previous night for exams, the next day early morning, person definitely will have few jerks, unlucky and big seizures.
Not many questions. Okay, thank you, Dr. Sinha.
Yes, ma'am.
Thank you. Yeah, thank you.